my hospital will examine clinically include biceps, subscapularis, supraspinatus, infraspinatus, and teres minors. Before the examination, the ultrasound operator needs to perform the following points. First, distinguish the patient. Second, understand the cause and the time of the injury in the context of the examination. Third, evaluate the patient's condition. Use a simple physical examination to check the degree of the patient's injury, and then start the examination. When we check different ligaments, we need to match different postures to check the condition of the ligaments. We will ask the patient to rotate the arm externally to check biceps and subscapularis. When the patient is akimbo, we check supraspinatus. Finally, ask the patient's arm to be in a bent and adducted position to check infraspinatus and teres minor. These pictures shows the postures we ask the patient to do during the examination, and also show the position of the ultrasound probe. During the scanning process, we will change the direction of the probe to observe the ligaments in the transverse and sagittal planes, then store these images. Special thanks to my colleague for posing these poses and letting me take pictures. Thank you. After the examination, the images will be stored for the radiologist to report, and remind patient go see the doctor next time to read the result. During the screening, the ultrasound technician will encounter some conditions that are not good for the inspection, such as a patient's inability to coordinate with the proper posture or agitation, and it may even be difficult to observe the ligaments with ultrasound, because of an operation on the patient's affected side. These are some examination cases. The first patient reported that she had seen a doctor because of shoulder pain for many days. We performed an ultrasound examination and found no abnormalities in the biceps. However, abnormalities were found in subscapularis and supraspinatus, which can be observed from the echo. These two ligaments are thick and echoes are chaotic and inconsistent. These two ligaments are also the two with the higher rate of injury in the rotator cuff. And last, infraspinatus and teres minor have no echoes inconsistency or ligament thickening, indicating that neither is abnormal. In the next, case 2, no abnormal echo were found in the biceps. The left picture is transverse view, and the right picture is sagittal plane. Compared with case 1, the echoes on subscapularis and the supraspinatus in case 2 were consistent, and the ligaments were not thickened. However, in case 2, there was some fluid around infraspinatus and teres minor. The image report showed that the radiologist more favored there was a possibility of bursitis. So we can see the right image. The arrow shown here have some hypoechoid around the tendon, and the radiologist favored it was a possibility of bursitis. And this here, teres minor, also shows some hypoechoid around the tendon. And here is the comparison between case 3 and case 4. Left side is case 3 and right side is case 4. We will compare the ultrasound images of these two cases. First, we can see that there is a circle of hypoechoid area around the bicep in case 3, showing that there is some fluid and the probability of bursitis is higher. But in case 4, there is no special finding. Here we can still observe that there is some fluid around subscapularis in case 3. The ligaments are also thickened, and in case 4, some calcification of subscapularis can be observed. Here, the calcification is over here. Next, observe the condition of supraspinatus in the two cases. In case 3, supraspinatus was not observed, and there was some hypoechoid area in the original position of the supraspinatus. Therefore, comparing with the case 4 on the right, we can observe the obvious difference between the two. And the image report also mentioned that the supraspinatus in case 3 is highly likely full thickness tear. And in case 4, it was found that there were hypoechoid area around the tendon, around the supraspinatus, indicating bursitis. The infraspinatus in case 3 here is also full thickness torn, which is obviously different from the case 4. In the right picture, we can see from the left picture where it should be infraspinatus, only some fluid but no echo performance that ligaments should have. And except for bursitis, there is no obvious abnormal echo in the part of case 4 on the right. In my point of view, shoulder ultrasound has a proven accuracy in rotator cuff assessment. However, this examination relies heavily on the skills of ultrasound technicians. Therefore, a wealth of anatomical knowledge, accumulation of clinical experience, and keen observation ability are necessary. In addition, whether performing ultrasound examination of the shoulder or other body part, When we face patients, we need to listen patiently, face them empathetically, and perform exams for them professionally. Moreover, we also need to continually improve our knowledge and skill to accumulate experience in order to provide the best examination quality when examining patients. However, the premise of all is that we also need to take good care of the body before we can contribute our strength. So proper rest is vital. Thanks for listening.
Okay, I think ultrasound is another one of very important imaging tool for a clinical diagnosis. It's very interesting. And thanks for our speaker for this section. Then I think we are going to the next section. Please.
Yes, thank you very much, Director Cheng Wei Li. Now let me introduce to you and let me call on now our moderator for the Part 2 session, Alice Chang.
Hi. Hello, I'm Alice, and I'm in charge of the second part. I would like to introduce the next speakers. So, the next speaker is Maggie Tseng. She currently serves as a diagnostic radiographer at Zuoying branch of Kaohsiung Armed Forces General Hospital. And her topic is using non-invasive way to reduce allergy rates of iodinated contrast while doing CT enhanced procedures. So welcome to Maggie Tseng.
Hi everyone, glad to have you online together to share and exchange our working tips. I'm the speaker today, Maggie Tseng. Today I'm going to share a working tips with you. The topic is using non-invasive way to reduce allergy rate of iodinated contrast while doing CT enhanced procedures in my department. Simply describe the background of these working tips. During our work, when a patient who admits for undergoing enhanced CT procedures, we will ask them to fill in a contrast injecting permit form and medical and allergy history form to get their permission and understand their medical history. Some of the patients may experience some symptoms such as nausea, itches, rashes, dyspnea, eczema, or the worst is shock after injecting iodinated contrast. These symptoms we count as contrast allergy. Part of those patients may choose to undergo alternative exams, but some of the patients have no choice. They must still undergo enhanced CT scan to get the diagnostic result of following their disease. According to the description of allergy symptoms from patients themselves, clinical site will give some preventing actions to reduce their allergy rate. In my hospital, our consultant majorly using 3 ways to reduce the chance of allergy while doing scan. The first one is IV injecting normal saline 30 minutes before exam start. using this way to increase patients' fluid volume, helping patients' body to wash out contrast quickly. The second one is IV injecting chlorpheniramine or methylprednisolone before patients undergo enhanced CT procedures. The dose of chlorpheniramine or methylprednisolone depends on how serious of their allergy symptom is. Mild reaction will inject in 30 minutes before exam starts. Serious reaction may inject in 4 to 6 hours before exam starts. The third one is oral prednisolone 30 mg tablet 1 day before undergoing exam. In this sharing, we exclude the patient who has bad eGFR or creatinine, kidney function failures patient, allergy to chlorpheniramine or methylprednisolone, patient who is restrict taking water, or anuria patient. However, patients sometimes refuse to use those invasive ways to prevent their allergy rate of iodinated contrast. They may question doctor whether the enhanced CT scan is their only choice, or they refuse to go through injection twice or more because of their scare of needle injection. Or some of them may feel so troublesome. This is easily happened in elders, or they scare of experience allergy again, so refuse to try. Due to those reasons, we noticed that the cause of allergy is from two parts of view. One is patient's physical condition, such as their family history, medical history, patient who has diabetes, and so on. And the other is patient's mental thought, such as anxiety or resistance. Therefore, we discuss a non-invasive way to satisfy patients' physically and mentally needs. That is, giving water for patients to drink before they undergo exam in 30 minutes time. We use physical way to increase body fluid volume, same result as using normal saline IV washing. Moreover, drinking water is easy to prepare and widely acceptable by patients. We choose those patients who had contrast allergy experience before, but still have to undergo enhanced CT scan again to involve in this study. And this brings some advantage to different role of people. For patients, it reduces their anxiety of undergoing enhanced CT procedures, and they can finish the procedure without experiencing uncomfortable feelings. For CT team radiographers, patients will be more cooperate in this procedure and get our work more efficiency and produce the high diagnostic value images. For clinical sites, it reduced the patient's arguments or questioning, and they could get the high diagnostic value of report, which might influence their next treatment decision. We collect the data within a year, discuss with the clinical consultant and our radiologist, and most important is get the patient's agreement to have a try. In the end of a year, we totally get 50 patients fit in our requirement who had allergy experience but willing to try this non-invasive way to undergo enhanced CT exam again. After drinking water, 39 over 50 patients have no allergy symptom at all after injecting iodinated contrast. It shows a good result of these tips, but it exists some bias in this working tip. Like our sample size is really small, and this tip is only suited for those patients who had mild allergy symptoms, and basically who had allergy history won't undergo the same exam again. They normally will discuss with their doctor and wish to choose the alternative one. But from the feedback of patients, drinking water is quite a good way to try compared to taking preventive medicine or medical actions. This is my sharing today. Thanks for your listening. If you have any questions, please do not hesitate to ask. Thank you.
Okay, thank you, Maggie's excellent presentation. And next speaker will be Yan-Lin Liu. He currently performs the role of the researcher at University of California, Irvine. He's going to give a keynote speech about diagnosis of non-mass-like enhancement lesions on DCE-MRI by using Radionics and deep learning. So welcome to Yan-Lin Liu.
Hello everyone, my name is Yan-Lin Liu. I'm come from Taiwan. Now I'm working at the Department of Radiological Science, UCI. Today I want to make a short presentation, the diagnosis of non-mass-like enhancement lesion on DCE-MRI by using Radiomics and deep learning. For breast lesion detection, three modalities are often used for breast lesion detection in clinical examination. Breast MRI is an important modality for detection of the lesion. Due to its strong soft tissue contrast, it has become a clinical examination used for mammography and ultrasound for diagnosis of the breast cancer. Dynamic contrast enhancement MRI, we call it DCEMRI, is a well-established imaging method to evaluate the vascular property, which can be used for diagnosis benign from malignant lesion. According to the BI-RAT, breast lesions on MRI are divided into the three categories. For example, things like a tumor have the focus enhancement, or the mass and the non-mass enhancement. For the mass lesion, this can be easy to detect by all the imaging modality and the diagnosis with the high accuracy. The diagnosis of the non-mass enhancement lesion are more challenging. So why the non-mass is more challenging than mass lesion? For the mass lesion, the intensity of the lesion is the difference than other breast tissue, but in the non-mass, the lesion boundary cannot be easy to find out. For the non-mass enhancement, the fifth edition of the BI-RAD has further revised the category for morphology distribution and the internal enhancement pattern. However, there was a substantial overlap of some descriptor between the ligament and the benign lesion, and difficult to make an accurate diagnosis. To detect the non-mass enhancement lesion as likely to be malignant or benign is more difficult, and the machine learning-based CAD may provide a visibility tool to make an accurate diagnosis. In recent years, radiomics and machine learning have been extensively applied in medical field. Radiomics analysis can extract many features from imaging and convert them into the quantitative data. For the deep learning using the convolutional neural network is also very emerging rapidly, and it has been shown as a feasible method for the diagnosis without using predefined feature extraction algorithm. So in this study, the object of this study was implement radiomics and deep learning using the ResNet 50 to build a diagnosis model for discrimination malignant and benign non-mass enhancement on MRI. As you can see this table, there are a total of the 175 non-mass enhancement patients, and the exclusion criteria were patients receiving any period treatment or poor image quality, and seems like a motion artifact. We will just exclude those patients. So finally, we can gather the 150 patients, include 104 with the malignant, and the 46 patients with benign lesion were included in this data set. This figure shows a classic example of a morphology distribution and the internal enhancement pattern evaluated based on BI-RAD. This patient with the 47 years old diagnosis with the adenosis showed the focal distribution and the homogeneous enhancement. This patient is 41-year-old diagnosis with the DCIS showing the segmental distribution in heterogeneous enhancement. This patient is 43 years old, diagnosis with the IDC, showing the segmental distribution and the cluster wing enhancement. This patient is 36 years old, diagnosis with the inflammation, showing the regional distribution and the heterogeneous enhancement. 41 years old, diagnosis with IDC, showing the regional distribution. 52 years old, diagnosis with DCIS and the multiple distribution. In those 6 cases, all of the reader give the consistent BI-RAD category result. So first, we will introduce the deep learning workflow. So at first, we will segment the tumor ROI using the fuzzy C-mean algorithm. And after we gather the ROI region, we will generate the 3D DCE map and use those map as the input. So, and use ResNet 50 to input those images to make a diagnosis model. So there are 3 DCE parametric maps that defined below were generated. The first one is the wash-in single hole enhancement. The second one, the mass single enhancement. The third one is the washout slope map. And this is a case study. This patient with the 63 years old with the IDC, and this image shows the F1 pre-contrast image, and this is the F2 post-contrast image, and we also just label the RI in here. And the figure C, D, E, F, that means it's the F1 pre-contrast image, and this is the lesion area. And for the D image, that is the F2 post-contrast. F3 post-contrast. And the last one is the F6 post-contrast imaging. And these three images is the DCE parametric maps. And this is the time frame imaging with the different intensity. So this is the F1 and the F2, F2, F4, F5, and F6. So as we can see, the DCE time course shows a typical washout pattern, reaching the maxima in F3, followed by decreased intensity from F4 to F6. This is another case study. This patient with the DCIS. So as we can see, the tumor, the lesion is in here, and the DCE time course shows the pattern seems like very stable after the F3, and the maxima is in the F3. So this patient with the is a benign patient, and as you can see, after contrast, the DCE time course shows the enhancement from F1 to F6. This figure shows the flow chart of the radiomical analysis procedure. So the first, the tumor is a segmented on the F2 minus F1 subtraction imaging using the body SME, and then the tumor ROI is mapped to three generated DCE parametric map. On each map, the 107 parameters are extracted using Radiomics. They are used for feature selection by using SVM, and then for building the classification model using 5 different machine learning algorithms. The 8 features were used to build the model. Those features is extracted from the Radiomics. And in the training data set, the achieved accuracy was 80%, 77%, 75%, 75%, and 71% for SVM, decision tree, KN, and LDF, and maybe bias. When those models were also applied to the testing data set, as you can see, the accuracy is about 77%, 75%, 67%, 70%, and about 62%. But for the ResNet, as you can see, the accuracy can achieve the 91%, and the AUC is 0.9. So the ResNet is better than the Radiomics model. And for the training data set, as you can see, the ResNet 50 also higher than the Radiomics. This figure shows the ROC curve generated from the predicted pure lesion malignant probability in the training data set, and by using the ResNet 50 and the 5 different machine learning algorithms. As we can see here, the ResNet have the highest ROC. For the second is the Radiomics model using the SVM with the Kaohsiung kernel. So that's the one. The better one is maybe bias. In the result, as we can see, the SVM with the Gaussian kernel have the highest accuracy compared to other algorithms. So it can be reached 80% accuracy, both in the training data set and the testing data set. Since like there is not a lot of difference between training and the testing data set. And for ResNet, in the non-mass enhancement data set, as we can see, the accuracy is higher to 91%, and the 83 in the testing data set. The deep learning had the better diagnostic performance compared to the Radiomics model. And some researchers has also indicated that the deep learning will have the better diagnosis accuracy. For the higher level flexibility, not limited by the predefined feature using the certain computer algorithm. So that is because the Radiomics have the 107 feature that we extract from the RY imaging. So those features was the fixed. So sometimes when we use the Radiomics model, it seems like the limited by predefined feature. So in this study, the case number was small, and the non-mass enhancement was further than mass lesion difficult to assemble the data set. The tumor ROI was segmented using the body imaging algorithm, not including all the cancer tissues. Non-mass enhancement boundary is not clear, there was no golden standard method to perform the segmentation. So sometimes we will manual drawing by radiologist, not a good option. Sometimes will lead even the higher variation. In summary, radiomics and the deep learning method will implement to investigate their potential to provide machine learning-based care tool, and the higher accuracy was achieved. The value of the AI model in diagnostic radiology is well recognized, most in providing additional information for radiologists, not mature yet for making diagnosis recommendation. Thank you for your attention.
Okay, thank you, Yan-Lin. And it's an amazing presentation. So I think we come to the last speaker, Zuoying. He is also a radiographer at Xinguang Wuhuoshi Memorial Hospital of Radiology. His keynote speech is about analysis of the advantages of oblique chest X-ray photography used for lesions detection in COVID-19. Welcome to your way.
Hello, sir and seniors who listening online. I'm a radiologist at Xinguang Hospital. My name is Zuoying. The topic I want to report to you today is analysis of the advantage of oblique chest X-ray photography used for lesion detection in COVID-19. And here is my outline. At the end of 2019, there have been multiple cases of unexplained pneumonia in China. The WHO named it COVID-19. In response to central policy, our hospital restrict and control the number of people entering the hospital and build an outdoor isolation screening tent. Any patient with suspect symptom, travel history, or contact history should undergo out of hospital isolation and screening. The patient's symptoms of COVID-19 are fever and respiratory tract infection. Therefore, RT-PCR and chest X-ray are the main item for detecting this disease. The mobile X-ray machine can quickly screen the chest health of suspect case and provide important information for screening. Chest X-ray can diagnose pneumonia, pleural effusion, lung abscess, or cardiomegaly. COVID-19 may include fever, cough, dyspnea, sore throat, nasal congestion, muscle pain, headache, and the respiratory symptom can be checked through chest X-ray. Therefore, chest X-ray AP view is indispensable for routine chest examination. In conventional PA position, the size of the heart can be clearly seen to determine whether the heart has functional abnormal, such as left and right heart hypertrophy. However, because of the characteristic of X-ray, there will be an uncertain area behind the heart. We call it retrocardiac space. And the high effectiveness of COVID-19. It's not possible to confirm the patient does not have pneumonia. It's easy to cause admission, especially when a patient has cardiomegaly. The patient has a normal heart size, but will still be a small part of the area behind the heart that is not visible. These patients suffer from left ventricular hypertrophy. The area behind the heart is not covered by a large field, and there are many uncertain areas. We decided to add RPO projection. The RPO projection, this article will focus on it. CT has high diagnostic value, and because the risk of infection, negative pressure must be established, but it's expensive and cannot be archived. Chest X-ray can be quickly diagnose pneumonia, but an area uncertainly will appear behind the heart. The chest X-ray lateral view can show the lung lobe more completely, but the image quality is not good due to lack of complete equipment at screening station, and the patient required high cooperation, so this method is not used. Many COVID-19 cases has lesion in the lower lobe of the lung. You can see this patient has lesion here. But due to characteristic of X-ray, the heart will just block the lower part of the left lung. Therefore, this study used RPO view, the position method, turn the angle of the heart way. So the area behind the heart can be displayed completely. We collect patients who were examined by chest X-ray during isolation screening in our hospital, including patients with mild symptoms who only received PA1 view examination, and patients with respiratory symptoms or TOCC, who were examined by PA RPO 2 view, and were diagnosed in hospital. A total of 67 patients with suspect COVID-19. Including 26 male and 41 females, with an average age of 40.5 years. The image were evaluated by 2 visit staff in radiology department. The more senior physician has more than 30 years of clinical experience, and the other has more than 10 years. The chest AP position we use exposure condition is 76 to 85 kV and 2.4 MAS. The RPO projection we use 81 to 85 kV and 3.2 to 4 MAS. The analysis comes from portable chest X-ray image. Among 67 patients, 5 patients with fever and no TOCC only use AP view, and 62 patients use AP and RPO view. Of these 62 patients, 13 patients could not be present completely, and 49 patients can fully present retrocardiac space in RPO image. After using RPO view, the angle of heart can be turned away, so the lower lobe of the lung in the posterior area of heart can be fully displayed. These 2 patients, the retrocardiac space can be fully displayed. You can see the patient on the left. The heart is superimposed on the spines, and the posterior area of heart can be fully displayed. The patient on the right has a problem with cardiomegaly, and the area that was not visible in the AP view originally. With the help of RPO view, the heart is turned away and the posterior area of heart is completely displayed. Because everyone's body and heart size are different, there are some difference in the position angle. For example, when the 2 patients were in position, the angle rotation is too small, and the heart is not turned away, result in complete presentation. When the 2 patients were in position, the rotation angle was too large, which caused the lung area to be seen to overlap on the spine, and did not turn the heart away, which affect the diagnosis effect. The patient has the problem of different body shape and heart size. Therefore, we mark the angle from the heart to midline of the body in the CT image. The patient on the left has large body and heart, and the angle is 40.8 degrees. And the patient on the right has smaller body and heart. The angle is 34.2 degrees. So when we're using RPO position, the rotation angle is between 35 to 50 degrees. Then we compare the result report by the 2 doctors. First, when only use AP view for diagnosis. The diagnosis result of Dr. 1 is 18 people without lesions and 31 patients with lesion. And Dr. 2 has 21 without lesion and 28 with lesions. After adding RPO as a diagnosis, the result of 2 physicians were simply similar, with 29 patients without lesion and 20 patients with lesion. The specificity and sensitivity of result can be seen to improve. The uniformity of doctors' diagnosis showed that there was non-significant difference in p-value greater than 0.05. However, after only using AP view and increasing RPO view, the discrepancy between different diagnosis results, there was significant difference. The p-value less than 0.01, and the overall diagnosis result is improved by 49%. According to the result of study, the used RPO view can show the area behind the heart that cannot be reached by AP view, which help to improve the diagnostic benefit during COVID-19 screening. And it's easy for patients to cooperate. However, RPO view has some limitations, such as the different size of each patient body and heart, which result in different position angles. If the patient is confirmed to have TOCC, but cannot be diagnosed by CT and need to undergo X-ray screening at screening station, it's recommended to add RPO view in addition of the regular AP view to make the area behind the heart can fully present and improve the diagnostic benefit. Thank you for listening. This is the end of my report.
Okay, thank you, Zuoying, and that is a wonderful presentation. It's good to learn at this moment. Thanks our 5 outstanding speakers. We hope that the viewers of today's talk can gain great insight from their wealth of knowledge in professional field. So next, we move on to the Q&A section. So I'll start with the question from the panelists. Is there anyone who would like to ask any question?
Yes, I have a question. I have a question.
Yes.
Okay. My question, first question for Jian-Ren Ciou, the first speaker.
Yes.
Okay. Yes. How many cases in your research? How many cases?
16.
16.
Yes.
Yes. I'm agree. You are well. You use SWI very early for diagnosis, very early for metastasis in brain, very early, and non-contrast. I'm agree. But I see in your research, I only see early staging, maybe early staging. For example, I'm a doctor. I send request for you. I have my patient in lung cancer. I thinking in metastasis in brain. I send for you. You check MRI. I see you are early. Summer lesson very early, very simple. You use SWI. Okay, but you remember very simple. Yes, like a cyst in brain. But some metastases have a edema, have edema around. You miss the summer metastases have edema around. You see?
Yes. So I think the SWI is just can support to detect the brain metastasis. It's still need to do the control enhanced MRI to confirm it.
Yes, sometimes affect the mass affect they affect in another one. And I think you very early better. Early staging very bad. But I think now in your hospital, for example, I send for you in my patient in lung cancer. You automatic use the SWI, and you don't use your CET1. You don't use CET1.
No, we use both of them.
Yes, both of them. Yes, the first the CET1 first. After that, the SWI.
And SWI is.
For example, I think in my patient have a metastasis in brain. I said for you, what you choose, the first the CET1 or the second you use the SWI.
And the first choice is I will choose the CET1 first.
Yes, after that. Okay. Congratulations. Okay, thank you. Very good. Very good.
Thank you.
Yes, very good idea. I think everyone learn from in your research. SWI very important for early diagnosis in metastasis in brain. Thank you. The second speaker. I have a question for Chia-Hsien Chien. I have a question. I understand in your we use in ultrasound for rotator cuff is very important. But I don't know because in rotator cuff, some patient no need to operate, no need, only drink medicine and exercise. How about in your hospital? For example, you choose ultrasound first, patient bend shoulder, and you choose the first ultrasound. When you patient move to in MRI for exam.
When we do the sonal examinations, then we will call our doctor. When we doing the examination and the patient still in the room, then we call the doctor to come.
Yeah.
Better show the examination image, then and tell the patient to do some gesture to see the tendon have any maybe bursitis or some tears. If the image cannot show clearly, then we will use some like a MRI or some scope.
Yeah, I know.
To see the tendons. Yeah. So we still need to doctor to examination to evaluate first.
Yeah.
Yes.
I think if some person don't need to operation, maybe with ultrasound enough and medicine treatment for patient. Okay. We follow up patient. After that if patient want to operator, we can MRI late.
Yeah.
Okay, thank you.
Thank you.
The number 3, the third Mary Tyson. I ask question for you. If you recommend for everybody, I see one problem very important. My question again, patient drink water. How many minutes before ingested CT contract in the CT scan? How many minutes?
In my hospital?
Yeah. I asked the number 3 question, number 3 for Maggie Tseng.
Maggie, sorry.
Yeah. Speaker, the third speaker.
Hi.
Yeah. How many minutes before drinking water?
I understand your question.
Yeah.
We normally give patient drink water before we start the procedure, 30 minutes.
30 minutes before. So how many milliliters?
250 milliliter to 500. Depends on how much water patient are able to drink.
In your research,
but at least 250.
Yeah. Your research, I think, are very important. The first time I hear, yes, drinking 30 minutes.
It is not really a research. It's just a small tips we try to do.
Yeah.
And it is a more acceptable way for patient to do it before they start the scan again.
Yeah. Because some in we see before the VCT scan abdomen for patient, we usually for ingest the contrast. We usually for drink the water, for in bigger stomach.
Yeah.
Yes, I think okay. But
if those kind of exam patient is already have to drink, then we won't give more water for them to drink.
More water?
No,
yes.
We won't.
Yes, we want more. Then the second question for you, Mary. For example, patient after when you inject a contrast for patient, I don't know, in your hospital now, patient have a problem after you just finish in injection. Patient have a nose, have a pain abdomen. What you do?
We will post the exam.
Yeah.
We will put the patient safety at the first.
Yeah.
So after that, we will deal with patient's allergy symptom first.
Yeah, sure.
Then we will call the clinical doctor who ordered that exam for request to do that exam. And
clinical doctor.
Yeah, because the medical exam request is from clinical side. So we have tell them his or her patient's condition, whether they still want to proceed or they want to do some prevention before they restart again.
My question, when the patient have a nose, have a pain, abdomen, everything. Yeah.
We'll just stop.
You stop and you invite a clinical doctor?
Yes.
Okay. You remember because some person have a shock that if you invite in clinical doctor, maybe late, maybe.
So I say patient safety first.
Yeah.
So we deal with patient's condition first. After the patient is safe, then we call doctor. But the procedure will just stop.
Yeah. Yes, I see in my country, not yet, because I see Insuring have adrenaline on the way already. Adrenaline and already. Radiographer or nurse near the patient. If patient shocked, you see in hypertension, her rate to have a problem. After you remember, we always have a sharing adrenaline on the ready. We can put for patient 1 minute or 2 minutes. Very important. I don't know how in your hospital we only no need in doctor, no need because some you check some the radiographer and you check patient in hypertension or her rate patient. We can use very important only 1 or 2 minutes. We use adrenaline. Adrenaline we push for patient very soon. My experience. I don't know in your hospital. Okay.
Thanks for your sharing.
Thank you so much. Thank you. The last question for EUV. The last question your EUV. Thank you for your you share your experience for everybody. We check X-ray for patient COVID patient. You use AP and RPO. Very important. You share for AP. You have a compare to AP only and RPO and AP together. To export for patient. I think very important. I understand if in COVID-19 patient, if you check patient, I think you are checking patient first. We use a CT scan, very difficult. I think you use X-ray, AP, and RPO. Now, in your hospital now, everybody use AB and RPO together, automatic. EUA.
Yes. For now, we will decide the patient has TOCC. If not, we just use AP view.
AP only now?
Yes. If
not automatic. Yeah.
Yes, if not has TOCC, we just use AP view.
Yeah.
And if has TOCC, we will use two view, AP and RPO.
Yeah. Who in what who patient what patient who in you have check X-ray for a COVID coming before they coming in your hospital? Respiration symptom. Patient have a respiration symptom. You must check X-ray for patient.
Yes.
Yeah. Okay. I think my experience in COVID-19. I think maybe in your experience. Last time in Vietnam also, but last time we also in COVID we also call it COVID zero COVID policy. We just do that. But now in have 2 or 3 short vaccine, and now we stop something. Okay. Thank you. Today I see in congratulations in Taiwan. You have 5 speakers, only young speaker. You have a good plan for in training for young people in Taiwan. Congratulations again. I hope in young people in Taiwan have a good future in good develop. Thank you. Thank you.
And thank you. So, is there anyone who has a question?
I think I have one question for Dr. Liu Yan-Lin. In my opinion, as we know, the parameter of MRI scans is very important to decide the image quality and the contrast. So, how do you think in your studies, and how to decide a parameter so it's significant for your AI study, and it can significant for your study?
Okay, thank you for your question. So actually, so as in this study, so I using the DCE-MRI, right? So, but actually, those data are from different hospitals. So some hospitals, they maybe have the 5 DC time frame, right? The first is the post pre-contrast. Maybe they have the 4 or 5 post contrast. So in this study, we're using the 3 parametric map. So we want to use these 3 parametric map to just like normalize those images, because as we know, we got those images from one hospital. So maybe those patients have the lesion, and the lesion maybe have the high intensity, but compared to other side images, so maybe the middle intensity, those patients maybe have the same as we will diagnosis as the malignant. So when we collect those images, so we will set in we will not set in the parameter. So for those hospital, we will collect those images since like a very different, because when we get a more different imaging to build a radiomics or deep learning model, that we can say those model can actually use in the hospital, right? Because of those model we want to finally can help to diagnose this malignant or benign. So actually, to be honest, if we can get a more different imaging, and things like a different protocol, and you know the different manufacturers such as GE and Siemens, and this is a different manufacturer. And as we know, so when we do the breast MRI, right? So the breast, different breast, so will affect the image quality. So we have to do the pre-processing things like the bias filter to normalize those images to get a better image quality, and then we input those images to the deep learning or radiomics model to build the perfect model. So actually, sometimes we don't want to get or maybe those hospitals have the same protocol. We hope they can use it. Sounds like they have the different voxel size, and they have the different sizes, or maybe they have this machine will 1.5 Tesla, and one of the MRI have the 3 Tesla, and for that different parameter, they can help those model can actually used in the help to help doctor to diagnosis. Yeah.
Okay, thank you.
Okay, thank you. Any questions?
Okay. Yeah, from me. Yeah. For the first speaker, Mr. Jian-Ren Ciou. Yeah. Is it this sequence for SWI? Is this for your suggestion? Is this possible for all kind of tumor or any specific tumor? Hello?
Can you repeat?
Okay, yeah. For the sequence of SWI, is it possible for all kind of tumor, or just specific tumor for the examination.
Suryanto asked you in we use SWI. You get profits. You get profits. Within the early staging for metastasis, the best, the first. He asked you with another tumor, we can use SWI. How profits get from in SWI?
You can detect the kind of the tumor is breeding. Also, it has a microbreeding. It can also detect it. Microbreeding tumor.
Yes.
If we don't have a microbreeding, SWI maybe not can be used of it.
I think the SWI. You research for in metastasis brain, but I think SWI detect for us. Some are small in lesson, some small lesson. But you want to diagnose it correct, make sure the diagnostic, you must do next step, another sequence. Okay.
Yes, we need to combine other sequence.
Yes, we compare with another sequence. Not only as the summarize SWI detect for you in very small summer lesson. Okay, with in metastasis brain. Okay, good, very good. But another tumor, not sure. We must compare with another sequence. Okay. Yeah, thank you.
Okay, thank you.
I think, in my opinion, I think SWI for brain tumor detection, I think it's it's useful because in some reference we can see there are some brain tumor lesions that they have the feature of microbreed in the lesion. So I think SWI can to detect the small lesion. So in our hospital, sometimes we used to SWI technique for detect the small and then maybe not very clear for contrast enhanced T1 image. Then we can compare these two different these two different image, and to make a better diagnostic for brain metastasis lesion.
I have some comment about the susceptibility weighting imaging. I think the susceptibility weighting imaging is good for detect the minor hemorrhage. It is very good. But the problem is not to use in the metastasis, right? Today the research, the topic of the Mr. Ciou and Mr.
Yes.
Sukiento to asking about the can use for the other tumor, right? So, but the susceptibility imaging we will know because the red blood cell they have iron. So we can just only use for good for the hemorrhage, right? If the tumor you have hemorrhage, bleeding, so we can detect very well, right?
Yes.
Yes. I think the conclusion is this. Okay, thank you.
Okay, thank you. Is there anyone has a question? So I think we have come to the end of today's forum. Let me take this opportunity to once again thank our 5 distinguished speakers for today's informative and stimulating talks. Also, I would like to thank all of you for your contribution and the conference ends successfully because of your participation. So now I would like to hand over to our president.
Thank you, Alice, and thank you for your attention, and see you next time. I wish all of you have a nice day. Thank you.
Thank you so much, Alice Chang and Cheng Wei Li, and also to the TAMRT, Taiwan Association of Medical Radiation Technologists President Jian-Ren Ciou. Now, in the interest of time, we have to cut from here so we can give way for the closing session. So again, thank you so much to all our distinguished speakers, very young ones, but very good ones. We have learned so much from your very interesting and important discussions. And this time, I know everybody's excited to know the next exciting events that we will be having soon. So for this, I'd like to call the President of Singapore Society of Radiographers, President Dennis Chun, to give us an invitation.
Thank you, Peachy, and thank you everybody for attending today's session organized by the Taiwan Association of Medical Radiation Technologists. Congratulations on your successful conclusion of your conference. So I'll take a few minutes just to tell you about the upcoming 8th Southeast Asian Radiographers Conference. So that will be held online virtually from the 25th to the 27th of March. That's going to be a Friday to Sunday. All right, we have an exciting lineup for you because it's going to be held in conjunction with the 9th Asia Radiotherapy Symposium as well, and our 5th annual scientific meeting of the SSR. So the theme for the conference is going to be Leadership in Radiology, Preparing Today's Professionals for Tomorrow. And we can see a lot of young presenters and participants here today. So they are going to be our leaders of tomorrow, and we want to prepare everybody as best we can for this transition. So we're going to have a few speakers who are actually well-known leaders in our field. One of the ex-presidents of the International Society of Radiological Technologists, Radiographers and Radiological Technologists, the ISRT, Dr. Tyrone Goh will be presenting at one of the sessions. And we also have a very famous author. Her name is Ms. Ruchira Chowdhury, and she is an executive coach for leaders in business schools. And we've managed to, she has kindly accepted our invitation to come and speak to us. So this is her book. She's written a book on coaching, The Secret Code of Uncommon Leadership. Yeah, so she will be giving us a lecture on leadership, what it is to coach others to become leaders as well. And we have a few workshops organized as well. So this will be one on leadership, one on diagnostic radiography, and then one on radiation therapy as well. So it's very exciting. I hope all of you can attend. Registrations are now open already. So, and we also have a grant that is available for some of our radiographers who might be in need of some additional subsidy for the conference fees. And all this information can be found on our website. We go to ssr.org.sg, or you can visit our Facebook for the link as well. So we hope to see you there. We would also be very happy to have your participation in our poster competition. We're going to open the poster viewing on the Friday morning. So we would like to invite everybody to go, and you can actually vote for a poster that you really, really like as well. And that will actually be taken into the consideration for the scoring of the poster. All right, so we look forward to your participation. See you all at the 8th Southeast Asia Radiographer Conference in March. Thank you.
Singapore, Singapore, please more discount for Asia CPD member. More discount.
Yes, we're still trying to work that out actually. Hopefully we can reach out to more of our participants from the Asia CPD program. We'll see if we can make some sessions available as well, maybe free of charge, but we will work that out and we will let you guys know as soon as we've worked out all the details.
Can you tell us, President Chung, when is the registration going to end? So
it will close, I think. We just need a few days before
March
the conference itself to make sure that everybody has their login links and all those things available. So it will close, I think, on the 23rd of March. Yeah. So you still have a good, maybe about 60 over days, about 2 months, yeah, to register, but don't hesitate. You can put in your registration early so that we can make sure that everybody has access to the conference on the day itself.
Well, there you have the very young also president of SSR. From your words, dear President, that sounds very, very interesting. We would like, as much as we would like to physically meet each other, as we have hoped last year, but obviously probably not this time. But we will surely be giving our support to the Southeast Asia Radiographers Conference and the next Radiation Therapy Symposium, and definitely support the SSR activity. So thank you again, President Dennis Chiu.
Thank you, everyone.
All right, so in closing now, we thank you and congratulate Taiwan Association of Medical Radiation Technologists, President Chun Yuan-Tu, all your officers and all the organizing committees of the 13th CPD Asia. We thank you, and we thank all the support of the IT CPD Asia technical team, all the participants and registrants of this online platform, and most of all to all our presidents, officers, and representatives of our dear radiological technological societies in Asia. So for this, we would like to see you again on the 14th online CPD Asia. The next schedule, the 2022 CPD Asia online platform schedule, will be out very, very soon. So please keep updated. See you again in the next activity. Again, this is Peachy Luna and saying to everyone, good day and keep safe. Thank you.
Thank you.
Thank you.
Thank you.
Yes.
Fernando.
Thank you.
Thank you.
Thank you, VG.
Hello.
Very well.
Thank you for support Indonesia, Paris.
Yes.
Yeah. Okay.
Thank you. Thank you. Thank you, everyone.
Yeah.
See you all.
Thank you, President John, Joan Yu. Yeah.
Bye-bye, Dennis.
Recording.
Baik Bapak Ibu, demikian tadi CPD Asia ke-13 dengan host Taiwan. Terima kasih atas kehadiran Bapak Ibu. Dan Mohon diisi untuk post-test dan absensi akhir. Sekali lagi sampai jumpa di CPD Asia ke-14 dan seterusnya selanjutnya. Maka dengan berakhirnya siaran dari Taiwan, maka CPD Asia ke-13 ini berakhir pula. Dan kami masih menunggu post-test dan akhir rekan-rekan hingga 30 menit ke depan. Sekali lagi terima kasih, sampai jumpa di CPD Asia selanjutnya.
Before you leave, remember to subscribe to our Instagram and see you soon for the next episode.
Angkat aku bagi
Before you leave, remember to subscribe to our Instagram and see you soon for the next episode.
Baik, izin meeting